Thank you, everyone. Now we're going to move into the data science and artificial intelligence and visualization tracks. So first up, we have Team 5.
Okay, so this is a collaboration between IUPUI and UCLA. So we built a system that will do early warning detection of opioid clusters. So you can imagine you have this opioid overdose in this blue dot here in Indianapolis. And for a variety of reasons, say it's a bad batch of drugs or a new drug on the street, you can get these spikes in overdoses. So here's an example we found in the news where you had 52 overdoses in 32 hours in Louisville. So given that initial event, how do we get an early warning signal to intervene and prevent those after overdoses from occurring? So what data did we use to solve this problem? We're using toxicology reports from Indianapolis. This is location, date, and drugs present in the system, combined with EMS run data, so calls for service to the location and times of overdoses. So our modeling approach to try to predict these clusters is two parts. So the first part is what's called a Hawkes process. This is a model that can model these clusters in space and time. So it'll give you an estimate, given an overdose, how many events are likely to occur in the next week or two, how far in space, like 1 or 2 kilometers away, are they likely to occur. Now, what we found when we analyzed this data is that the type of overdose matters a lot in terms of how many overdoses are going to occur after an initial event. So in particular, we found some categories or topics of types of overdoses where, for example, in the case of this third category involving fentanyl and cocaine, you had about 21 events on average in several weeks after initial overdose that contain those drugs, whereas overdoses that are more related to prescription and accidental overdose have much fewer events after them. So how do we come up with these drug topics or categories? And this is important because if you have a new drug that you've never seen before in your city, how do you know how risky it is? So we have a 3-part model to do this. The first part is we take these drugs that are present in the toxicology report, and then we take their chemical compound structure, and there's methods that you can use to map that to a vector. Essentially, the vector is just 1 or 0 indicating what chemical substructure is present in the molecule. Secondly, overdoses aren't just one drug. On average, in this Indianapolis data set, there's 6 drugs present in the tox screen. So we need to be able to compare overdoses with other overdoses. So to do this, we're using what we call the drug movers distance. So here, if you have one overdose that's morphine and cocaine, we take their vector embeddings that we created from the previous slide, and then we compare those to the nearest chemical in another overdose. And you take the average of those distances. That's called earth movers distance. We're calling it drug movers distance. The cool thing is that if you have a new drug you've never seen, you can still compute this earth movers distance based on the chemical compound. And so you can still do this. Then we apply spectral clustering to these distances to get our topics or our categories of types of drug overdoses. In the top left, there's a fentanyl-related category. The bottom left is related to prescription opioids. And then the green and the black are involving illicit opioids, one involving alcohol and one involving benzodiazepine. Okay, so we're going to give a quick demo of a little tool we envision. A city like Marin, we heard about yesterday, Matt Willis was saying he wanted to have a tool where he could, in real time, see threats from opioids. You know, how many are we likely to have in the next week? Where should we distribute resources? So we have a little web app that we can kind of walk through the history of Indianapolis, and you might use it then as a predictive tool. So if we like stop on one of these days, like here, like say this is today. So each of these is an overdose death that we've gotten from a toxicology report. And so the size is predicting how many events we think are likely to occur in the next several weeks. So you would use these to rank areas in the city. You might have limited resources. Indianapolis has a mobile crisis unit. They only have like 2 or 3 of these cars where they pair a paramedic with a police officer with naloxone. So you might park those cars in those hot spots to get there more quickly. If you're somewhere like Marin that is much more innovative than probably Indianapolis, you might be willing to put needle exchanges, safe injection sites, maybe safe drug testing sites into those areas. And the important point is these are dynamic. They're changing. New drugs are always coming on the market. So how can we, in real time, adapt to those threats? So this is an app to do that.
Toxicology reports typically take 45 days to 90 days. It's not really real time. So your model seems to be heavily focused on coroner's data and those toxicology screens. So help me understand that. How is it real time and helpful if you have to wait so long for those tox screens?
Yeah, so I'm not a chemist. I don't know if it's possible to expedite those. We've heard talks yesterday that said you could, in a minute, have a breath screen and screen for a number of substances. So we are illustrating this with toxicology reports. You could couple it with that sort of breathalyzer as well and do this same sort of thing. So there's still obviously work to be done, but I think that could be solved.
So, related question, based upon that, the same problem. If you actually could do this, I see this more as a law enforcement tool than I do as one for interdiction, for helping drug abusers and overdoses. In other words, you talked about putting police and
Yep.
naloxone. I could see also the police would be using it to stake out dealers. Thoughts?
Yeah, I think as we've heard, this is a multifaceted problem. So the long-term solution is on probably the prescribing side, alternative medicines. Like a medium-term solution is maybe these behavioral change apps. But people are dying like right now. If we could, position naloxone, or better yet, have safe injection sites in these areas in Indianapolis, we could probably save lives like today if we did that. So this is like a short-term stopgap until we have, I think, the long-term solutions.
Okay, thank you.
In terms of the uniqueness of your system, would you say is this a visualization tool or the backend prediction model?
I mean, there's a back-end prediction model. The Hawks process is running in the background. This dot is not a plot. This is a prediction. We're visualizing a prediction, but this is a prediction.
Have you verified how accurate your prediction is?
We did this in a day. Like we didn't have this prepared. Like we just did this today. We hope to write a paper at least and maybe implement this, but we'll have to compare it to some baseline models that we didn't have time to do.
Do you have, since waiting for the time to run out, how scalable is your solution? Can you deal with a huge amount of data?
No, because these Hawks processes scale quadratically in the number of events. So if you're trying to fit these to Facebook data and you have billions of events, that's not going to be feasible. But for the opioid problem, it is scalable because, for an example, in Indianapolis, they have about 10,000 events, in the data set of overdoses in the EMS database. That's N squared is fine for that. So in terms of the US, this could be scalable across the country.
Thank you for that. Next up, we have Team 15.
Thank you very much, everyone, for being here. We are here today to talk about the MAT scorecard, new metrics for direct action at the county level. This is our team. So Patty and I are both current medical students, and we've both completed fellowships in data science for research purposes. We also have David Schrager on our team working remote, who is a clinician and a professor and a data and statistics editor at JAMA, as well as a few other journals. So we hope to build in this proposal on some of our other work, including an ongoing collaboration with the California Department of Justice to analyze PDMP data cures. So this collaboration has already led to a few peer-reviewed research articles that have focused on the social epidemiology of the opioid crisis in California. So the motivation for this proposal is that we believe that medication-assisted treatment has been proven to work. However, there's substantial evidence of disparities in access to MAT along lines of race, income, geography, and healthcare access status. We believe that county-level stakeholders have the power to enact change to ameliorate these disparities, but they will need straightforward metrics that benchmark their progress relative to other counties and show them where and how specifically they can intervene. And so we've created a couple of metrics that we hope can do just that. Our first metric is an index of the intensity of the epidemic. So this combines the rate of overdose deaths, the rate of ED visits, and inpatient hospitalizations that have to do with opioids. And so this provides a single snapshot of the intensity of the epidemic by locale. And we benchmark this to other counties in California so each county can see how they're doing. Next, we produce an index of MAT. So this is based on the percent of the population receiving MAT per year. This is also benchmarked to other counties in California. So this is helpful, but we need to understand it in the context of how much epidemic is actually occurring in each place, right? That's the way this can be the most useful. So our third index does just that. We calculate the level of MAT for the amount of epidemic intensity in each place. And this answers the question, how successfully is the epidemic being treated in this locale, in each county or in each zip code? And here you can see an example of how this looks benchmarked. Additionally, we provide modifiable factors for each county that can be used to improve their score. So in the domain of treatment, this includes the number of MAT providers. We want to make sure that there are enough people working who are registered to provide MAT. We also provide the average number of patients per MAT provider, because we've seen that in some places there are plenty of providers, they're simply not seeing enough patients. And finally, we provide the percent of MAT patients receiving buprenorphine as opposed to methadone, because it's a newer treatment that has been shown to be more effective in many cases. In the domain of prevention, we provide the percent of adults receiving an opioid prescription each year in the hopes that this factor can be reduced. And as a future direction, we hope to include the information regarding naloxone distribution for harm reduction and also reducing the demand for opioids through educational and counseling programs. So let's take a look at our scorecard visualization. Okay. So here we have the visualization for Los Angeles County. And so scrolling down, you can see that most of the epidemic in Los Angeles County, or much of the epidemic, is concentrated in northern LA County. It's a little more rural. And interestingly, you see that here, the treatment in LA County is actually concentrated in this band of wealthy Zictas stretching from Malibu into Hollywood, right? And so you can kind of already start to see visually that there's a bit of a disparity here. And many of us who have spent time in LA can imagine the social factors that cause this disparity to exist. Coming over here to our index that highlights disparity, you can actually see that while Malibu into Hollywood, they're doing pretty good, relatively speaking, benchmarked to the rest of the state, most of LA County is actually not doing that well relative to the state. And so up here in the scorecard, you can see that while LA County is in the 40th percentile of the intensity of the opioid epidemic, they're only in the 25th percentile of the MAT index. And that has resulted in their place in the 22nd percentile of the treatment of the epidemic for the amount of intensity, right? The amount of MAT for how bad the epidemic is there. Sure. So we're using, for most of the intensity of epidemic, metrics. We're using publicly available data from the Department of Public Health, and then we're using data from Cures to calculate some of the MAT metrics.
Thanks for your presentation. Some of those data sets also have a significant lag time, especially the previous one, and part of the category is real time. There's also another group that's done something very similar. I don't know if you've seen the urbanpolicy.org, but that's not real time. It's kind of similarly structured. How would yours be real time? How does it differ from what's already in existence?
Thank you. That's a great question. So one of the future directions we're hoping to take with your support is as we're actually about to renew our data use agreement with the Department of Justice, and so we're hoping to push for sort of rapid data updates to make this data as actionable as possible. And I have seen in some other contexts that data may be available quarterly, for example, or like preliminary data sets have been provided from Cures.
So this might be digging a little bit too much in the weeds, but do you know anything about their capacity as either reporters, data collectors, or either their system to be able to fulfill rapid updates? And what does rapid mean?
Yeah, so that is a fantastic question. I think one of our main goals with this would actually be to anchor both our research and the design of this prototype, like the expansion of the design, in the needs of our community collaborators. And so many counties, for example, I believe do have more rapid access to Cures data. Many people have access to Cures data. And so I think a lot of what we're hoping to do moving forward with your support is figuring out the precise way for this to be implemented that it will make the most sense and be the most useful for our stakeholders. And I know that many community groups do use Cures data, and so we're hoping to streamline that for them in a very straightforward way.
What stakeholder groups would you see seeing the most value out of this tool, and how would you engage them?
So I think one of the best advantages of this tool is that it's relatively easy to understand. And so perhaps a sort of a coalition where there are diverse stakeholders and they all need to understand what are the key issues, how is our county doing, and kind of giving everyone on the same page of the basic progress of their county or even their neighborhood. And so I think that would be sort of the best case. Does that answer your question? So if there are no further questions, I'll just add a few comments about how. So one thing we're really excited about is the idea of potentially expanding this network of benchmarked indicators. So every state has this kind of data, and to our knowledge, there really hasn't been that much crosstalk between states. Once in a while, the CDC does something with this data, but it's very macro, and it's sort of been hard for me to use in the past. And so what we'd like to do is make a very targeted county or community-specific approach that's a network and that highlights success stories, shares information, and promotes county-to-county collaboration, even across state lines, because in many cases, the state line is rather arbitrary.
And in terms of continuing our work, Joe and I have worked in the past. We actually did a fellowship up in Seattle and worked with Dr. Schweiger, and I think we have the fundamental capacity to be able to take this forward, and we're very excited to do so.
Yeah, our research team meets regularly, and it would be very feasible for us to continue this research and even host a viz, but the main thing we do need is community buy-in and anchoring our process in their knowledge. So, thank you.
Which part of the work was done previously and what part at this hackathon?
Yeah, so actually, I would say 99% of this was done in the last 24 hours. That we built the whole viz, we calculated the metrics. We have used this data before. So actually, I think looking at the viz, the only metric that we had before was this prevention metric, which we actually just published a paper on, but everything else was calculated in the last 36 hours. Thank you very much.
Thank you, Patrick and Joe. Next up, we have Team 18.
Oh, it was very loud. I'm Karen. This is Aram, Christine, and Sujong. We're all students and researchers at the Pardee Rand Graduate School, which is part of the Rand Corporation. We are getting our PhDs in policy analysis, and we all have pretty different backgrounds, but we can cover that at the end. So it's here. We built a machine learning model to predict opioid overdose deaths in California at the county level. Our goal, we built a predictive model. We identified key risk factors for the next opioid crisis, and we visualized those in maps for each California county. And out of the 58 counties, like 2017 opioid overdose deaths sorry, that's worded poorly. In 80% of the counties, we predicted within 10 fatalities for 2017 using data from 2015 to 2017. Our overall framework was we were thinking that things that would affect the outcome, which is opioid overdose deaths, would be like supply, so prescriptions, demand, like likelihood of using painkillers, demographic information and socioeconomic conditions, so things like race, socioeconomic status, health information like the use of other illicit substances, and availability of treatment, so number of pharmacies, places that dispense naloxone. We looked at more than 130 of these predictors, and we conducted an exploratory analysis to see which of these variables were significantly correlated. We tried a bunch of different models and ultimately used the forest regression. So do you want to talk about the?
Sure. So we eventually decided to predict on the county level because, well, first of all, we want to use publicly available data sets, and also we want to kind of try to help improve the local awareness at the county level. So we experimented on a bunch of machine learning models from the Manila linear regression, including some regularization techniques. Eventually, we found that a random forest regression gives us the best results. And basically, it's like a model that combines classification and regression. It kind of just like a decision tree that partition data into different compartments and then fit regression lines on those compartments to get a better performance on the predictions.
So we pulled the data, like variables from like multiple data sources, like at the national and county level. We wanted to try to cover like all those major dimensions of like opioid crisis, including supply, demand, and also like social, like demographics and socioeconomic factors, and also like health information by the county level, and also like treatment availability too. And these are the list of like predictors, significant predictors. So these were like highly correlated with the outcome variable, which is like the number of opioid overdose death. So from the supply side, obviously the prescription data, the number of prescription, and also like the number of doctors with like high opioid prescription rate was like significantly like correlated with the outcome variable. And from the demand side, because there is no like direct measure like to measure the demand for opioids, so we had to like create a predictor or a proxy from like a nationally representative data using like demographic information. And we predicted like using the combination of like demographic information for California. We used the parameters as a predictor. And for demographics, it seems like education level and economic indicators such as the number of like unemployed people are highly correlated with the outcomes. And then the health information such as like the history of like STD, thank you, and like the number of like mental health providers seems to be really, highly correlated with the outcome. And for the treatment availability, the number of like pharmacies and also like the number of physicians like prescribing buprenorphine seems to be highly correlated with the outcome variable. We visualize these outcomes with interactive maps at the county level. So you can take it up.
Okay, so if you see this first graph is the actual overdose deaths from the opioid, and the second one is the predicted overdose cases based on our model. And then the last one is the predicted error, which is the absolute number of the difference. So if you see each county here, can you go to the other way? So the Santa Barbara has 32 overdose deaths last 2017, and then when we predict based on our model, it said it's 35, which is kind of really close number. And then so these are the predictors which we think it is really interesting because we thought maybe these predictors are not related to predicting our. Okay.
130 indicators. The actual number of data sets went down because we only ended up using these significant ones. I think it's about.
Okay. You started out with 130 and you ended up with how many?
About
Sorry?
30.
These turn out to be significant.
Yeah, these are the significant
So
ones.
20.
So we cut it down to like 20. Actually, I guess, well, everyone was talking about how nothing, like it doesn't discriminate, and it's true. Like most things were not relevant.
Most of the demographic.
Most of the
demographic and demographic factors. are not
Okay.
predicting.
And so random forest, I don't understand what that is. I'm just a community person. I'm just trying to find out how do we get ahead of this. What do I need to do? Do I look at the squiggly lines and the circles up there, or do I look at the map? Help me, help you, help me, help you.
Yeah, I think the focus is on the maps. We just trying to use different models to better predict the outcomes that we care about. And we want to look at what are some features that actually we cannot neglect when we're looking at this overdose. As you can see that aside for the actual outcomes, we also found that there's other factors that are actually important that you need to consider, like social security issues, other risk factors like other substance abuse, and also the access to primary care.
So did you use a lasso, let's say, to limit? What did you use?
Yeah, so we try doing some regularization using lasso reach regression, but eventually we found that it's still not performing as well as like random forest.
Regular,
Right.
And you had some training set that you.
Yes, so we try to combine several data sets, aggregate them into county level, and then it's actually a small data set. We are hoping to get more granular data, like in terms of time scale or geographic locations, etc. But so far, the public available data that we use are at the county level, and it's an annual basis.
I mean, the goal is for the idea is this would be for policymakers so they could concentrate like on the local, at the county level, like where do you fund like. I mean, our data is from 2015 to 2017, so it's not quite real time, but it was able to predict. Even the 2015 data was useful for 2017. I mean, this is not causation for sure. It's just like a correlation, but these might be like if people see like, oh, there's very high cases of this in this area, like maybe more funding should be placed there. Yes?
So and thank you for the presentation. It's very interesting with the prediction models, but your use claims data, and it's Medicare claims data, but then you're looking at SES, and so Medicare claims data, obviously, you're excluding a significant portion of the population. So how do you account for that in your prediction models? Because and self-pay and Medi-Cal or Medicaid patients are not really represented there, although you're using it with some of the other determinants. So it's a little bit confusing.
So Medicare data is for the elderly people who are going to have a prescribed pills. But I think we found the literature saying there is no big difference between the Medicare providers, opioid prescribing behavior, and the other behaviors such as from the Medi-Cal providers. So we read that literature, so we think we can generalize the result from the Medicare into the general population. So thank you so much.